The following podcast is part of a certified educational activity titled The Path to Viral Hepatitis Elimination, Enhancing Screening, Vaccination, Treatment, and Care. Access the entire activity and complete the post-test at peerview.com/UDA860. Downloadable slides and practice aids are also available.
Hello, and thank you for joining us. My name is Dr. Paul Kuo, and I am a professor of medicine at Stanford University. I'm pleased to be joined today by two uh, hepatologists, Dr. Tatiana Krishner from Cornell Medicine and Dr. Nancy Rowe from Rush University. And together, we're going to talk about the path to viral hepatitis elimination, enhancing screening, vaccination, treatment, and care. Our goals for today are to advance your skills in evidence-based screening for and prevention of viral hepatitis to promote earlier diagnosis and increase vaccination rates. We're also going to equip you with strategies for improving timely diagnosis and monitoring of viral hepatitis. And finally, we're going to provide guidance on creating personalized treatment plans for patients with hepatitis B, hepatitis C, and hepatitis D infection. So let's get going now with addressing gaps and new guidance in screening and prevention for viral hepatitis. So, first, we're going to bring up a case. Let's meet Rick. So, Rick is a 55-year-old gentleman. He's referred to gastroenterology for MASLD or metabolic associated steatotic liver disease follow up. He's had a FibroScan, which shows F2 fibrosis at 9.5 kilopascals with a CAP score of 300 decibels per meter. His serologic evaluation for other forms of liver disease is unremarkable. However, upon your chart review, it demonstrates that there has not been screening for viral hepatitis in the past. So, what tests are we going to order for Rick? So, when we talk about screening for viral hepatitis, there have been multiple recent updates, and we'll start with the updates for hepatitis B. So, in 2023, the CDC updated their screening recommendations to include screening all adults age 18 years or greater at least one time. And this was really a much more straightforward, more effective, and less stigmatizing strategy. Historically, we had, for many diseases, performed risk-based screening, yet we miss many individuals, and the risk-based screenings also may also have some patients being unwilling to get screened. However, with a one-time screening test, we have a higher opportunity to make the diagnosis of hepatitis B, and again, can, as you will see, also bring forward other strategies, including vaccination. All pregnant people should be screened during pregnancy for surface antigen, preferably in the first trimester, regardless of vaccination status. This is because if you are positive for surface antigen, you may need additional measures to prevent transmission, and obviously you need an evaluation for treatment. We also test susceptible people periodically if you have ongoing risk factors, and we're going to go over these risk factors a bit later. And this is regardless of age or prior, or those who have exposures that are ongoing. So, for hepatitis B, what does the CDC recommend? It recommends the use of a triple panel. So, what are these three tests? They include a surface antigen, as well as a surface antibody or anti-HBs, and also they test for the presence of hepatitis B exposure with the total anti-hepatitis B core antibody. And periodic testing can be used based on the results of this triple panel. So, how do we interpret these serologic tests when you obtain results? So, this table here helps us to understand what actions need to be taken based on the results. So, if your surface antigen, core antibody, and surface antibody are all negative, then these are individuals are susceptible, and one should offer hepatitis B vaccination. If the core antibody and surface antibody are positive, they have a resolved infection. They are immune, but again, because of the proliferating biologics and immunosuppressants out there, they have the potential to reactivate if they require immunosuppressive or some other potential biologic therapy. And thus, we counsel these individuals on the potential for reactivation and if should they ever receive any of these classes of medicines. If the surface antibody is positive, then they are immune. And this is due to hepatitis B vaccination because the core antibody is negative. If surface antigen and core antibody are positive, they have ongoing chronic hepatitis B infection, they should be screened for hepatitis D. And finally, a total core antibody that is isolated most commonly reflects resolved infection. Rarely, it can be a resolving acute infection, a low level chronic infection called occult hepatitis B, or even more uncommon is a false positive anti hepatitis B core antibody. But these are extremely uncommon situations. So, core positive means resolved infection in almost all the cases you will encounter. What about the populations at risk for hepatitis B? Well, they're listed here, and you can see here that you can help determine these populations by looking at the medical history, the sexual and behavioral history, as well as taking into account social and demographic factors. So, if you've had a history of HCV or HIV, elevated liver enzymes, then these individuals are at risk for hepatitis B. Also, if patients have a history of sexually transmitted infections or multiple sex partners, men who have sex with men, injection drug use, or have shared needles, again, at risk for hepatitis B. And finally, those born to hepatitis B surface antigen positive individuals or come from areas where the prevalence is high, these individuals should also be screened as well. And vaccination is the primary strategy to prevent hepatitis B transmission. The multiple societies here, you can see here, ACIP, AAP, AAFP, and ACOG have all recommended that the first dose of hepatitis B vaccine be administered within 24 hours of birth for every newborn in the United States. And this again is the universal birth dose of hepatitis B vaccine. Why is this important? Well, it prevents mother to infant transmission. Indeed, the vaccine alone prevents 70 to 95% of transmission to infants born to surface antigen positive women. It prevents household transmission and protects infants from infected family members and other caregivers. And finally, provides protection if medical errors occur. This is a safety net to prevent perinatal transmission should there be, and it happens only rarely, a medical error occurring. And the hepatitis B vaccine can be administered for this reason. What about those who require serologic testing prior to hepatitis B vaccine? This would be done again to see indeed if they have chronic hepatitis B. And this serologic testing again comprises surface antigen, core, and surface antibody. These include, again, household sexual and needle contacts of surface antigen positive individuals, HIV individuals, those who have known elevated AST, ALT, uh, those in hemodialysis units, again, injection drug use, men having sex with men, and those persons who are from countries of high endemicity, where the surface antigen prevalence is above 2%, or those born who's in the US who were not vaccinated and whose parents were born in countries with high endemicity as well. Finally, persons who require immunosuppressive therapy, as we mentioned earlier, and donors of various semen, blood, plasma, organs, tissues, etc., should also be screened with serologic testing. Here are the vaccines that we have available to us. And again, the ACIP and CDC have all recommended universal vaccination of all patients ages 19 to 59 with the hepatitis B vaccine. And those above the age of 60 with or without risk factors can also have this vaccine if they desire protection. Universal vaccination, again, removes the need for risk factor screening, and it also increases our vaccination coverage. There are three hepatitis B vaccines and one combination vaccine with hepatitis A and B. We have the Recombavax, Interjex, and Heplisav for hepatitis B. The two-dose adjuvanted vaccine, which can be completed 1 month apart, is probably the most effective vaccine simply because it's two vaccines. The other vaccines, while highly effective, they do require dosing at 0, 1, and 6 months for hepatitis B and for the hepatitis A and B vaccine. And thus, getting all three doses completed can sometimes be a challenge. Also, the adjuvanted vaccine also does have higher efficacy and actually is actually the choice for those who don't respond, that is the salvage vaccine, and those with risk factors for non-response. In addition, all vaccines are safe for use during pregnancy. What is considered protection from hepatitis B infection? So if the antibody titer of surface antibody is greater than 10 units, this is considered protection. A response is defined as greater than 2 units. Hyporesponders are those who achieve between a 2 and 10 uh, um, unit titer. And these individuals typically can receive just one additional vaccination dose, and they will then uh, achieve a level of greater than 10 after this dose. If you still don't respond or you don't respond at all, the non-responder options are to use the 2-dose recombinant adjuvanted hepatitis B vaccine series, or again, to revaccinate with a 3-dose series. What about testing for hepatitis delta? The WHO and EASL recommend universal anti-HDV testing in all individuals who are surface antigen positive. If universal hepatitis D testing is not feasible, then priority needs to be given to those at the highest risk, and these include those who come from endemic regions, those who have features suggesting HDV infection, particularly those who have high ALT, and despite having effective nucleoside therapy, and of course those who have HCV or HIV, who use injection drugs, or sex workers with hepatitis B infection. All of these individuals should also be screened. The screening process is to draw the anti-HDV antibody. And in surface antigen positive individuals, if this test is negative, it's standard of care hepatitis B management. If the delta antibody or D antibody is positive, then an HDV RNA should be sent, and further evaluation, including staging and potential treatment options, should be explored. To distinguish hepatitis D co-infection from superinfection, we use the hepatitis B IgM core antibody, which is indicative of acute hepatitis B infection, which also suggests co-infection if delta antibody is also positive. Most patients who are co-infected at the same time typically resolve their infection. Superinfections are much more likely to go on to chronic infection. And finally, about hepatitis C, all adults, again, we've gone from risk-based screening to universal screening, and all adults age 18 years or greater should be screened at least once in their lifetime, as should pregnant women, children born to infected HCV infected women, and finally, those with ongoing risk factors, including many of those risk factors we've discussed: injection drug use, hemodialysis, ALT levels. These individuals require periodic testing also for hepatitis C. And again, the screening test is an anti-HCV antibody. And if this test is performed, make sure that you order it such that you get reflex testing. That is, testing is available where the anti-HCV if positive can reflex to an HCV RNA in the initial test. If everything is negative, they have no current resolved infection. If the antibody is positive, PCR negative, they have resolved infection or were successfully treated. And if the antibody and PCR testing is positive, they have current active hepatitis C and should be treated for these reasons. Going back to our patient case, this is Rick. Again, Rick came in to us for a history of MASLD and has moderate fibrosis based on his FibroScan. As it turns out, his hepatitis A is total antibody is positive. The surface antigen is negative. Cora antibody and surface antibody are negative, and he's HCV negative. And we will transition over to Dr. Kushner, who is going to take us through simplifying, supporting, and expanding HBV and HDV diagnosis and treatment. Again, Tatiana, thank you so much for joining.
Thank you so much, Paul, for really that excellent overview of our current approaches to screening. So we'll start with hepatitis B, and similarly, we'll start with a case of a patient whose name was Christina. This is a 34-year-old woman. She was adopted and immigrated from China at age 5. She's currently 14 weeks pregnant with her second child, and she's known to be hepatitis B surface antigen positive. She reports that she was previously tested for HBV DNA and hepatitis B e antigen, but did not receive follow up and does not know these values. And this is not an uncommon scenario that I see in my practice where patients may be screened during one pregnancy and then not followed up until they are again tested during a subsequent pregnancy, and really is one of the challenges that we need to address with hepatitis B in regards to making sure that there's ongoing continuous follow up. So, for this patient, what would you recommend for her HBV testing at this time as well as management? So, first, I'll address a bit about the gaps in linkage to hepatitis B care. Patients with chronic hepatitis B in the United States really receive inadequate monitoring and treatment, and we've seen many studies reflecting this. There continues to be a lack of awareness of and adherence to AASLD hepatitis B treatment guidelines. And here I show some data talking about gaps in monitoring of patients with chronic hepatitis B and gaps in treatment. And it shows on the left that 44% of people with hepatitis B and advanced liver disease, cirrhosis, receive no appropriate blood work in order to stage and monitor their disease. And on the right, we see that 29% of patients with hepatitis B and cirrhosis and 11% without cirrhosis received hepatitis B therapy within 12 months of diagnosis. And we know that all patients with cirrhosis and hepatitis B really should be treated. So, this highlights the gaps in care that we have for patients with hepatitis B living in the United States. And healthcare provider related barriers, as well as patient barriers, include a lack of knowledge about chronic hepatitis B and the benefits of antiviral therapy treatment and disease surveillance. So, we still have a lot of work to do in order to make sure that healthcare providers are aware of the need to monitor and treat patients, especially those with advanced liver disease. High treatment thresholds are associated with poor outcomes, but timely and effective antiviral therapy is very beneficial in people with chronic hepatitis B. Antiviral therapy can inhibit hepatitis B replication, reduce liver inflammation and necrosis, prevent HBV DNA integration, which in turn can lead to liver cancer, stop or reverse liver fibrosis and early cirrhosis, and most importantly, reduce cirrhosis related complications, reduce HCC or hepatocellular carcinoma, and liver disease related mortality. So, for those individuals who qualify for hepatitis B treatment, as we'll discuss, there are huge benefits for their overall health. So, in the field of hepatitis B, there has been a discussion about what the current recommendations for treatment should be. And a large part of the discussion is focused on whether we need to think about just the hepatitis B viral load or also think about ALT, which is a sign of liver injury or liver inflammation. And increases in serum ALT are not always necessarily parallel to the degree of liver inflammation. And so, although we use it commonly in clinical practice as a surrogate marker, it may not actually reflect the degree of liver inflammation related to hepatitis B. So, the study on the right, with the charts pictured here, looked at about 300 patients with hepatitis B who all underwent liver biopsy, and they compared findings on the liver biopsies among those patients who had persistently normal ALT, or they called it PN-ALT, versus those patients who had ALT that was increased to 1 to 2 times the upper limit of normal. And we see that both in terms of the degree of necroinflammation and degree of fibrosis in the light blue bars, we still see that on biopsy, there were many people with persistently normal ALT who did indeed have significant degrees of inflammation and fibrosis. And so the thought is that perhaps we should think about expanding our treatment criteria to not focus so much on the ALT, but focus more on the hepatitis B viral load. And economic and disease modeling suggests that lowering ALT thresholds to expand antiviral treatment can potentially reduce hepatitis B related complications and death. So, how is this reflected in our current and evolving hepatitis B guidelines? So, we see here the major societies, really global and US based societies, that have made recommendations for hepatitis B treatment. On top here is the ASLD guidance from 2018, which is still the active guidance from AASLD. And in that guidance, the recommendation is to recommend treatment for hepatitis B if individuals have a viral load over 20,000 if they're E antigen positive, or greater than 2,000 if they're E antigen negative, but also have ALT over two times the upper limit of normal or significant histologic disease as seen on liver biopsy. If you look at the other guidelines, which were published more recently, they are a bit more expansive. So, the primary care based hepatitis B guidelines from 2020 recommend that anyone with hepatitis B DNA over 20,000 and abnormal ALT be treated, but not that they have to have two times the upper limit of normal. The Chinese guidelines that came out in 2022 also say that if HBV DNA is detectable and people have ALT over the upper limit of normal, then treatment can be recommended. So this eliminates that higher viral load threshold. Furthermore, the Chinese guidelines allude to the importance of considering age in treatment decisions. So, if HBV DNA is detectable and the ALT liver tests are completely normal, if an individual is over 30 years of age or have a family history of cirrhosis or HCC or other extrahepatic manifestations, then they should be treated. There are also US simplified guidelines published in 2023, which simply state that anyone with HBV DNA over 2000 and ALT over the upper limit of normal if their age is under 30 should be treated. But if age is over 30, then ALT threshold is not needed. And then if we look to the World Health Organization guidelines, again, you see a bit more expansive with no mention of ALT needing to be two times the upper limit of normal. And finally, the EASL guidelines similarly saying anyone with HBV DNA over 2000 and elevated ALT should be treated. In addition, we know that this year we'll have updated AASLD guidelines, which will likely mirror some of the other more recent guidelines to recommend a more expanded treatment approach. So, how do we treat patients with hepatitis B? What are our current treatment options? So, they're listed here. We have oral antiviral therapy, which includes any one of the agents listed here. So, there's entecavir, there's tenofovir alafenamide, and there's tenofovir disoproxil fumarate, TDF. In terms of duration of treatment, and this is a discussion that we often have with our patients when we first discuss treatment, really the recommended duration is long term until functional cure is achieved, although we know that functional cure rates with these agents are quite low. Additionally, dual regimens of TDF with either 3TC or FTC can be used as alternative regimens in settings where access to tenofovir therapy is lacking, but where there's ready access to HIV therapies. There are some specific recommendations in certain scenarios for HBV antiviral therapy, although largely it's pretty straightforward. So, in some settings where access to treatment and or cost are considerations, entecavir and tenofovir disoproxil fumarate are available in generic form, so can be accessible cheaper in certain settings. Antiviral resistance is most typically not an issue, but it's important to recall that you should avoid using entecavir if a person has a history of use of lamivudine because that can lead to resistance. In individuals who have bone disease or renal dysfunction, then those individuals should be treated specifically either with entecavir or tenofovir alafenamide TAF in order to decrease the risk of long-term effects on bone and renal health that can be seen with TDF. And in pregnancy specifically, TDF or tenofovir is the recommended agent. And as we'll see in the upcoming ASLD guidelines, tenofovir alafenamide now may also be considered in pregnancy, as now we have enough data in the context of pregnancy to also use tenofovir alafenamide. So let's go back to Christina's case. So, as you recall, she was a 34-year-old woman. She is tested for hepatitis B during her pregnancy. And upon testing, she's noted to have an HBV DNA over 200,000 units, and her ALT and creatinine renal function are normal. Her first child is surface antigen negative, which is good news. And after discussion, she decides to initiate tenofovir disoproxil fumarate since she is hepatitis B surface antigen positive and has an HBV DNA over 200,000, which is the recommendation in the context of pregnancy to treat for the prevention of mother to child transmission if HBV DNA is over 200,000, regardless again of ALT levels. So the next steps to discuss with her is initiation of infant hepatitis B vaccination at birth and the importance of vaccine series completion. So, we really want to make sure that we vaccinate all infants in the US, but in particular, those who are born to mothers with hepatitis B. We also want to offer hepatitis B immunoglobulin to the infant born to mothers with hepatitis B. We also want to discuss with the mom, Christina, about the importance of follow up and after completion of hepatitis B vaccination, importance of testing the baby with post vaccine serologic testing at 9 months. And then, importantly, a discussion about monitoring of Christina following pregnancy to make sure she continues to be engaged in care and treatment discussions are continued at the end of pregnancy and also postpartum. So, what are the current recommendations of antiviral therapy for children with chronic hepatitis B? So, if there were vertical transmission, which in Christina's case would be unlikely given all of the steps that we are taking to prevent vertical transmission, then there is a possibility that the child may develop chronic hepatitis B. We don't speak too much about treatment of chronic hepatitis B because guidelines are evolving and there are planned updated NASPGHAN guidelines specifically for hepatitis B treatments. But there is a systematic review and meta analysis of 14 studies in children under the age of 18 with chronic hepatitis B that looked at response to the antiviral treatments that we have available, including interferon. And you see the results here that that the children who were treated compared to those who were not treated, not surprisingly, had improved hepatitis B outcomes. Notably, here, the risk ratio for hepatitis B surface antigen clearance was 5.8. But it's important to recognize that many of the studies and children in these studies were treated with interferon as well. So, patient selection and timing of treatment are critical decisions in order to avoid overtreatment, maximize therapeutic benefit while limiting duration of therapy, and minimize risk for antiviral drug resistance later in life. These were the conclusions from this meta analysis. But more coming and updated guidelines, hopefully, coming soon from NASPGHAN. So let's talk a little bit about functional cure. I mentioned that with our existing antiviral therapy, the likelihood of functional cure is low, but fortunately, we have movement in the right direction and hopefully coming closer to having treatments that do achieve functional cure. So, first, what is functional cure? So, functional cure is a more durable disease control, which is associated with hepatitis B surface antigen loss and subsequently, ideally, the development of hepatitis B surface antibody. And we see in this picture here the viral life cycle where you start with HBV DNA being elevated in people with positive hepatitis B surface antigen status, fluctuating ALT levels, and subsequently you can develop decline of HBV DNA, which we are able to achieve with our current therapies. But a more durable functional cure is when we have uh, hepatitis B surface antigen positive status turning to hepatitis B surface antigen negative status. So, functional cure is sustained hepatitis B surface antigen clearance. So this is the study looking at efficacy and safety of bepirovirsen. I'll call it Bepi for short, in chronic hepatitis B infection. And this was really the first study to demonstrate an increase in functional cure rates over interferon or nucleoside analogs. This was published in the New England Journal of Medicine in 2022. And in this study, they looked at Bepi, which is an antisense oligonucleotide, in individuals with hepatitis B who were either on nucleoside analog therapy or not prior to the study. And in this study, you see on the right that they looked specifically at hepatitis B surface antigen levels over time. And over time, and specifically what's important here is the graphs on the right, which look at weeks after end of treatment. So we're looking at people who were on treatment and then for 24 weeks they were off treatment. In this study, the primary outcome, which was surface antigen loss, was achieved in 9% of the individuals who were receiving nukes and 10% in those that were not. And notably, what was found in this study is that baseline surface antigen levels that were lower were strong predictors of response. And so, although the cure rates here are not very high, they're 10%. I think it's very promising to see that we're beginning to achieve functional cure and also that we're beginning to identify certain subgroups of patients that may be more likely to be able to achieve functional cure. These are the safety endpoints from the Bepi study, and overall, the drug was well tolerated. There were some adverse events of special interest, notably injection site reactions, vascular inflammation, thrombocytopenia, and increased ALT levels. Few cases of renal injury were reported as well. And this is not the only drug that we're actively studying. So there are multiple mechanisms being actively investigated for the achievement of functional cure of hepatitis B. And in the field, the thought is that really combination therapy that combines different antiviral agents with potentially immunological agents would be the path forward in order to achieve higher rates of functional cure. So now I'll switch to hepatitis delta. Paul already covered earlier about the recommended testing for hepatitis delta. Just to remind everyone, really, patients with chronic hepatitis B, we believe that everyone should be tested, although guidelines differ a bit. But the way you test is you initially test with a delta antibody, and then you get an HDV RNA if they are antibody positive. In regards to treatment of patients, one question that often comes up is whether patients with delta hepatitis should be treated with nucleoside or nucleotide analogs for their underlying hepatitis B. And here you see a summary of the different guidance regarding treatment of hepatitis B. Generally speaking, the recommendation is that nucleotide analogs can be used in patients who have active hepatitis B replication. In addition, in terms of chronic hepatitis D treatments with existing therapies, there is a recommendation for treatment with pegylated interferon for about a year in patients who have active hepatitis D. How about newer agents on the horizon for hepatitis delta? So, bulevirtide is a medication that is a daily subcutaneous injection, and it is a medication that actually is already approved for use in Europe. It is not currently FDA approved, but it is available through the early access program in the US on clinicaltrials.gov. So, if possible, you can access bulevirtide for the treatment of patients with delta hepatitis here in the US as well. And some are also looking into the combination of pegylated interferon and bulevirtide together for the treatment of delta hepatitis. Additionally, we also have exciting advances in new agents that are being evaluated for the treatment of delta hepatitis. They are summarized here. These are agents that are in phase 3 of study or have been tested in phase 3. And we provide a summary here of the three different agents or combinations that are being studied for delta hepatitis. What we see here is on top, we have a Blue Jay drug, which is a monoclonal antibody, which has shown very rapid declines in delta hepatitis and achievement of a combined response of HDV RNA decline and ALT in a majority of patients on treatment. We also have the bottom combination, which is tobevibart and elebsiran, which is a monoclonal antibody with siRNA combination, also in phase 3 of study and seeming to have very positive results on HDV RNA levels, as well as declines in hepatitis B surface antigen titers. And then the middle combination, lonafarnib ritonavir, has also been evaluated and is associated with positive outcomes, although is associated with significant gastrointestinal side effects. And that's what we've learned from studying that combination of agents. And I'll end here about delta hepatitis, and I'll turn it over to Nancy, who will discuss hepatitis C. Thank you.
Thank you so much, Tatiana. Um, with the incredibly well-tolerated oral therapies for hepatitis C, I think that we've grown complacent. So, there's a lot of excitement about drug development, and when you are not actively seeing new agents in the headlines, you think that you're done. But I am going to recenter us that we are far from done with hepatitis C, and we're going to start this with Jessica. She's a 39-year-old woman. She's a current user of injection drugs. She was recently screened for hepatitis B and hepatitis C. This often happens when someone goes into rehab or might be incarcerated or just has a moment of health focused care. And she was found to be hepatitis C antibody positive. Her hepatitis B testing does show that she's immune due to vaccination. So, kudos to the people that went through Dr. Kuo's earlier discussion and recognized that she had risk factors, she needed to be screened, and she needed to be vaccinated. She has no evidence of cirrhosis, which is also not unusual in our younger individuals who are exposed to hepatitis C through injection drug use. And her antibody nicely reflexed to hepatitis C PCR or RNA, which was also positive. So we want to really engage her in treatment. So the next question is, what are the next steps for initiating direct acting antiviral or DAA therapy? How are we going to monitor her? And what kind of adherence do we need to achieve? So, this is just a reminder that our approach to hepatitis C is different because this is bimodal, which means that there are two very distinctly different groups in the United States that have risk factors. You can't treat everybody the same. So, we have a bump in our millennials, a dive in our Gen X's. Apparently, us in the Gen X generation, we're not particularly fun. And then our baby boomers also have another high, bump. And that was first recognized because our baby boomers were our birth cohort. And that was the first group of individuals we really focused on targeted screening. Now, as Dr. Ko has already outlined, we do near universal screening, in addition to extra screening in our higher risk subgroups, because we have a group of individuals that is actively being exposed and our younger generation, typically through injection drug use or high risk behaviors. And you can imagine you cannot treat your grandmother the same way you're going to treat your, oldest child. And so we have to match our screening and engagement strategies to be a little bit different to the group that's next to us. We also know that this millennial group often is young, are more commonly white. They are actively using injection drugs. They might live in non-urban areas such as the Appalachian states. And that's going to be a group of individuals that might be a little bit different to engage. So, our ASLD recommendations, and these, unlike our hepatitis B recommendations, are a live document. When something is brand new, it's automatically released into these documents with a little bit of a buffer time. And they are published by ASLD and the Infectious Disease Society of America, so IDSA, and they recommend DAA treatment for all people with hepatitis C infection with no lag. So, in Before, we used to talk about acute and chronic infection and watching someone for a period of time. That has all gone away. Once you know a person has hepatitis C, the next step is to engage them as quickly as possible to eliminate their disease and to decrease the risk of transmission. We do very minimal on treatment monitoring. That's safe. We know that unless a person is very high risk, so you're not going to neglect someone that you've elected to treat who might have liver cancer or decompensated cirrhosis. You would want to have a question as to why you would be treating that individual. But most people with non cirrhosis or well compensated cirrhosis require almost no monitoring while on treatment because treatment is safe and effective and leads to high rates of cure. So, sustained virologic response, which is the definition of having no virus 12 weeks after completing therapy, is a curative treatment. And we want to start using that cure message to the patients and the providers that we need to engage in screening and treatment because it's really satisfying to actually cure someone. We have two first line therapies. We can use glucosamine pibrentosphere, which is a once daily treatment, 3 pills once a day for 8 weeks, or you can use sofosbuvir velpatasvir, which is a 1 pill a day treatment for 12 weeks. Both have very similar efficacy. There's some subtle differences, but these are both incredibly good choices for the vast majority of our patients. All right. So, what about pregnancy? And I know that it seems like we're talking about pregnancy a lot, but as was already highlighted, one of our screening strategies to engage individuals that may not otherwise engage regularly with physicians is to find individuals who are either pregnant or are contemplating, birth control. So we are now screening a lot of our patients that are of a maternal age where pregnancy is possible. And our guidelines recommend hepatitis C screening in each and every pregnancy, not like one pregnancy and you have three more, you are already screened. Each time you're pregnant, you should be screened. And this is Dr. Kushner's data, and this is really exciting. So, this shows us that although hepatitis C is generally very well tolerated in our pregnant population, and our approach to hepatitis C in pregnancy is a little different than hepatitis B. In this big database that was collected between 2000 and 2016, the question was really, does previous infection or active infection have differences? And so previous infection would be antibody positive, PCR negative, active infection, antibody positive, PCR positive. And it shows that yes, although most people with hepatitis C will have a great low risk pregnancy, that there are a few things that we need to be aware of. The first is intrahepatic cholestasis of pregnancy. There is a much higher rate of getting ICP if you have hepatitis C that is active or hepatitis C PCR positive. This goes both ways. It means that you should, if you screen your patient and they have active hepatitis C, warn them about pruritus and itching so that if they become itchy, you can earlier identify if they have intrahepatic cholestasis of pregnancy. Do remember we do manage that a little bit differently. There are treatments and even some timing of delivery that is important. Also, if your patient develops itching during pregnancy, you want to make sure that they have been screened for hepatitis C. Although we have universal screening recommendations, doesn't always occur. And so you want to make sure that your ICP patients have been screened for hepatitis C. We also notice that there are some peripartum problems, such as preterm delivery and postpartum or antepartum hemorrhage. These are slightly higher. There isn't a lot that we can do preventative wise, but it is important to be aware of that risk so that we can be prepared for any complications during the pregnancy. Now, how do we manage hepatitis C during pregnancy? As I said, that this is a little different than our approach to hepatitis B. The most important things are females of reproductive age with active hepatitis C ideally should engage in curative treatment before they become pregnant. That is the least controversial way to address hepatitis C. Our ASLD guidelines really have no recommendation on treatment during pregnancy. There are not huge clinical trial data. There are some smaller clinical trials, and we're gathering data. So, if you have a patient who's pregnant with hepatitis C and they are on therapy, we would like to capture them into our data cohort, such as, so that we can learn more about this. We also know that the DAAs are presumably safe in pregnancy based on what data we do have in some animal models, but our current recommendation is to not actively engage a person that is pregnant with treatment unless it's a case-by-case scenario. So there are certain patients where treating them during pregnancy is definitely going to be an advantage for both the child and the mother, and you don't want to be afraid of treatment, but the vast majority of patients are treated either before or postpartum. So, our guidelines don't have current recommendations on treatment during pregnancy, which is very different than hepatitis B because there aren't a lot of clinical trial data. We do have some data, and it's important if you have a patient that is pregnant is on treatment, or you elect to treat that person during pregnancy. You want to make sure you report that data so we can continue to learn. But the guidelines don't actively make a recommendation. They say that this is a case by case scenario. DAA treatment is presumably safe based on the patient information and the animal studies that we have. And you want to engage your patient on a case by case scenario. So, if it is in the best interest of the mother and the child, you shouldn't be afraid of treatment. But the majority of treatment is going to occur either before pregnancy or postpartum. Now, if you do have a woman who is hepatitis C antibody positive or hepatitis C positive during pregnancy, you want to make sure you have that RNA. Like Dr. Kushner's data shows, it's different if your virus is active or if you were either exposed and spontaneously cleared or exposed and treated. Those positive PCR patients have a different risk. You want to make sure you understand their liver function and you want to screen to see if they might have advanced liver disease. So, although most pregnant individuals are going to be of an age where cirrhosis is not particularly common, it we do see that cirrhotic patients can become pregnant, and cirrhosis in pregnancy is a much higher risk place to be, and they are managed very, very differently. So, do not miss cirrhosis. We recommend that the antepartum and perinatal care is really the same. It's going to be based on the risk of the pregnancy, not because of hepatitis C. There isn't a known intervention to reduce maternal to childhood transmission, which is very different than hepatitis B. Although in our small subsets where hepatitis C is treated during pregnancy, both mother is cured and child does not have hepatitis C. But our guidelines do not advocate for hepatitis C treatment during pregnancy to prevent maternal to childhood transmission. We are going to remind you that if you're itchy, that intrahepatic cholestasis of pregnancy is more common in our hepatitis C PCR positive patients, and that you again should make sure that you recognize cirrhosis because here you need to coordinate with maternal fetal medicine, do that upper endoscopy to make sure you don't have a risk of esophageal varices, preferably before pregnancy, but in the second trimester if you didn't manage to get that, and that's going to dictate a lot of your management. All right. So, women that have hepatitis C that are pregnant have children that have a risk of being exposed to hepatitis C, of which a certain percentage, 5 to 15%, depending on maternal viral load and HIV co-infection, will have a child that has hepatitis C. So, how do we treat children and adolescents with hepatitis C? The most important thing is that you can. And sometimes it's much easier to treat a child than it is to treat an adolescent or an adult because you've uh, separated the infection from high risk stigma. We have our direct acting antiviral treatments that are approved starting at the age of 3. You just want to make sure that you can be adherent to the therapy, and you should consider this irrespective of disease severity. So you do not have to have advanced disease or extrahepatic manifestations of hepatitis C in order to consider treatment. But if you have advanced disease or extrahepatic manifestations of hepatitis C, many of the most common are skin findings or kidney findings. You absolutely need to treat the hepatitis C. Now it is to decrease the risk of those extrahepatic manifestations through curative treatment and not because of risk of future complications related to the hepatitis C itself. So you do have two oral therapies, the same two that are approved for adults. The difference is not that they are just weight-based, and that would be glecaprevir pibrentasvir for 8 weeks or sofosbuvir velpatasvir for 12, and that is starting at the age of 3. So just like hepatitis B, our direct-acting antiviral treatment rates are suboptimal. On this graphic here, you can see over time, starting in 2014, going all the way to 2021, so a little bit of a lag. You treatment at any time versus treatment within 1 year. Remember, we do not need to watch hepatitis C. You want to actually treat hepatitis C as efficiently as you can. Well, we've been a little more successful with that. You can see that these two dots of delayed treatment versus more immediate treatment are now converging, but that is at a barely more than 50% rate. So we are missing a lot of hepatitis C treatment opportunity, which really means that we are missing curative therapy and the ability to prevent transmission. So overall treatment rates are stagnant at 65%, actually decreasing. That is independent of advanced disease. So if you have cirrhosis or liver cancer, your treatment rate is a little bit higher. So compensated cirrhotics without cancer at 76%, with cancer decreased to 56% because there are some treatment limitations there. And our injection drug users, it's at 54.6%. That's really inadequate in a group of individuals that's at risk for transmission. So these are all very suboptimal, especially given that we are working towards viral elimination. And so, in this study that was done, at least one third of patients with viremia were not receiving direct acting antivirals. We have got to come up with different strategies. What are the benefits of sustained virologic response? Well, this is pretty, you know, no nonsense, easy to sell. We recognize that this is a curative therapy. You can determine cure 12 weeks after you've completed therapy, along with the push, maybe even to consider a 4-week window adequate. There's a pretty good correlation between SVR4 and SVR12. We know that curing a patient has multiple benefits. Some of the easiest are that you prevent disease progression. So you decrease the risk of liver fibrosis progression. So you're going to decrease the risk of developing cancer, decrease the risk of developing cirrhosis. You have a 90% reduction in risk related mortality and liver transplantation. So this is truly a very good curative therapy that has liver related outcomes strongly associated with it. On top of that, though, it does have a reduction in all cause mortality. When you look at a group of individuals that has Hep C compared to those that are cured or compared to the general population, you see decrease in cardiovascular risk, decrease in diabetic effects, decrease in all cause mortality. And so something about this immune modulating pro-inflammatory virus is driving other diseases of which you can make people live healthier longer if you get rid of the virus. And we do recognize because some people with hepatitis C are truly asymptomatic. Many do have symptoms, and you have improved quality of life. So, what does ASLD recommend post cure or post SVR? Well, if you are cured and you do not have advanced disease and you do not have risk for reinfection and you do not have risk for ongoing liver disease, you don't need any follow up. Cured, you are done. But if you obviously have risk of progression for liver disease independent of your Hep C, so you also have alcohol use disorder, metabolic liver disease, hepatitis B, you need to continue to engage with your friendly hepatologist or the person who's going to manage your liver. If you are at risk for reinfection, you need to be screened because we don't want to miss disease. Patients with ongoing risk for hepatitis C infection should be counseled about risk reduction. So even if you can't separate them away from the behavior, you can make that behavior more safe. And that is really important in our strategies to prevent reinfection. You also want to advise individuals to avoid excess alcohol use. I would also add on to here being aware of metabolic risk. Recent publications actually show that metabolic dysfunction associated steatotic liver disease is a significant risk factor for developing liver cancer after a person has been cured of their Hep C. So don't ignore the rest of the liver and the rest of the risk factors even after you've cured your hepatitis. So we would love to screen everyone and cure everyone. That is our goal. We should not lose sight of our goal. But sometimes it's a little bit easier to focus on enriched populations. And that's where we talk about micro elimination. So we know that there are places where people are going to have hepatitis C that might be a little bit easier to access and probably have a little bit bigger bang for their buck because they are also going to be at risk to expose other individuals to hepatitis C. And here we're talking at our patients that inject drugs, that are incarcerated, some are dialysis units, where the seroprevalence rate is much higher. And if you could cure these individuals, you're going to take a stronger impact on the community as well as the disease in that individual themselves. And in our incarcerated patients, it's important to outline that up to 34%, so nearly a third in some incarcerated settings, will have hepatitis C. The purpose of microelimination is to work towards elimination of hepatitis C by focusing on specific populations, not by targeted risk-based screening. Risk-based screening does not work, but enriching our screening strategies by looking at those so that we can and deploy a more aggressive screening strategy in a group that's at high risk is a way of achieving elimination at a faster rate. This does require some specific tools, especially if you're going to use active injection drug users. Here we're talking about point of care rapid diagnostic tests so that you can tell them actively and efficiently that they have Hep C and then give them treatment before they have left that setting. And point of care tests are actually FDA approved. So we have access to hepatitis C point of care testing. This does have some challenges, but if your screening strategy is appropriate, you can really limit the stigma, bias, and then lack of knowledge because you're targeting a group at high risk. That takes us to hepatitis C treatment as a prevention model. And that is especially true if you're working in microelimination or treating at risk populations. So there is no role currently for DAA for post exposure prophylaxis. So, needle stick injuries, high risk exposures, you do not treat them. You wait to actually see if they have hepatitis C because it's not quite as a high of a transmission virus as hepatitis B. And then, if they have documented hepatitis C, then you treat. People who have successfully achieved SVR no longer transmit hepatitis C to others. So it's a little bit like that HIV model. Zero is zero. If you do not have active virus, you are not going to expose those around you. So it has public health benefits. There's also large decreases in hepatitis C prevalence and incidence if you engage high risk behaviors that are successfully treated. So, injection drug users, if you can engage these individuals, you decrease hepatitis C in their community. So let's follow with Jessica. So she starts sofosbuvir glucosidase for 12 weeks. She's doing great. There's a little bit of motivational interviewing. So even though we don't have to monitor her for side effects, we do have to monitor her to make sure she stays on treatment, especially if that's something that's going to help her get through this course. So there's a few touch points just to make sure she's doing well during her treatment. We talk about the importance and readiness to stop injection drug use. So don't just cure her, also look at the behavior that led to the hepatitis C infection. And we want to be important with our other educational, messaging such as adherence, treatment as progression, prevention, treatment goal to achieve cure so that she knows that this is a curative treatment, and then those steps to avoid reinfection. Now, Jessica probably doesn't have advanced disease, but if you look at our graph here on the right, if you have F3 or F4, so this is pre-cirrhosis or cirrhosis, and you're effectively cured, your HCC risk is reduced, especially if you can demonstrate fibrosis resolution and you can prevent hepatitis C related genetic epigenetic changes. And so we know that we decrease liver cancer risk. Your liver cancer risk is going to persist if you have progression of your disease or no regression. And if you have other, um, you know, cofactors such as hepatitis B, hemochromatosis, mast cell, these are all going to increase that liver cancer risk despite cure. And these individuals absolutely need to be engaged in liver cancer screening. Now, the dogma is really if you're a cirrhotic, even with effective cure, you should continue liver cancer screening. And we bicker. I will see if maybe Dr. Kushner and Quo want to talk about this in our Q&A. But if you have a person who's got pre-cirrhosis, our previous guidelines recommended treating them just like cirrhotics. Post-cure, still screen for liver cancer. And we've become a little more permissive now that those individuals can disengage. But I would remind you, they have alcohol use disorder, type 2 diabetes, mast cell, their risk of progression is still going to be high. And I would absolutely continue to try to keep track of my patient that was F3 and cured because I think that their risk is not as mitigated as someone who doesn't have those other cofactors. I'm going to summarize all three of our sessions. Millions in the US live with chronic hepatitis B or hepatitis C, yet remain undiagnosed due to gaps in screening and awareness and absolute gaps in engagement and treatment. Universal screening for hepatitis B and hepatitis C for all adults greater than 18 years and older is now recommended to overcome limitations of risk-based screening, which does not work. Monitoring and treatment rates for hepatitis B remain low, driven by limited provider knowledge and poor adherence to guidelines. Hepatitis D is a severe infection or superinfection in people with hepatitis B, and improved screening and access to emerging therapies are urgently needed. And don't forget that we do have that that early access treatment program that Dr. Krishna outlined. Updated WHO and AASLD IDSA recommendations support broader treatment access for both hepatitis B and hepatitis C using universal DAA therapy for hepatitis C. And expanding treatment and improving adherence improves outcomes, prevents transmission, and supports our elimination goals.
Thank you very much,
Course.
Nancy and Tatiana, for those wonderful presentations. I would like to just follow up on a couple of just points that we've been discussing this past hour. And Tatiana, if you don't mind, I'd like to start with you. So, one of the things that we talk about with hepatitis C, and we all talked about reflex testing, but to really, hepatitis delta is a disease that is just has pockets. And it is just, I'm just sometimes in clinic every now and then I'm just surprised at who comes back Delta positive. You actually tried to implement reflex testing. You succeeded in implementing reflex testing. And could you just share a little bit about some of the challenges that you had with this? Because, it's a less common disease. And I know that that makes there are challenges when you set up a screening program for these rarer diseases.
Yeah, thank you for the question. So I think we've discussed that the recommendations for Delta testing are also varied according to society. And for example, the prior AASLD guidance still recommends risk based testing. But the challenge with that is that many patients, providers, even hepatologists are not fully aware of all of the risks associated with Delta. And similar to other settings, risk based screening doesn't really work in identifying all of the cases. And our colleagues in Europe have published several studies that describe their experience with implementing reflex testing. And we similarly try to do so in the US at our institution. And we were able to implement reflex testing, which meant that individuals who had hepatitis B surface antigen positive status, they reflexed directly to Delta antibody. The challenges that we experienced were that in our institution, there was a discussion from compliance and ethics and others to say that we don't want reflex testing to be the only possibility, that there should still be a possible standalone hepatitis B surface antigen test. And so we had both options. And so then the uptake of the reflex testing was variable. Our primary care colleagues were actually enthusiastic and there was good uptake. And in those settings where reflex testing was done, the time to diagnosis or testing of Delta was much quicker than otherwise. And it worked. However, the problem was getting it widely implemented across the health system, as well as some of the opposition from the different compliance and ethics individuals about the idea that, well, this is a rare infection, and are we sure we want to make this the only test available?
Got it. Yeah. But, and your efforts really are, in my opinion, really are to be lauded because I think you, if you will, have now showed us some of the highlighted some of the challenges. Yet, I think reflex testing is the only way we're really going to find the pool of hepatitis delta patients, not only here, but as in other countries, parts of the world. This is how they find delta cases. I agree with that.
I agree. And there's also a recent publication on the cost effectiveness of universal delta hepatitis testing. And I think that really helps provide even more justification that not only do we think that it will identify more cases, but it's actually cost effective in a US based setting.
Sure. I mean, taking care of end-stage liver disease is just quite expensive. We can find them sooner, particularly with therapies on the horizon, and hopefully we'll be here very shortly. Nancy, so one of the things about the hepatitis C that you had mentioned was that it can be straightforward to treat. Are you and any of your patients now adopting any of the simplified regimens, say that the ASLD has implemented? We're starting to do this in our outreach clinics, and actually it works pretty well that we can do this, and we're encouraging some of the referring doctors to adopt this. We've had good uptake with this. I've always believed if you can treat Helicobacter, you can treat hepatitis C.
Yeah. Paul, I absolutely agree with you. And a while ago, we had a program that we called Test and Treat, where we held the hands of our resident population that was in primary care clinic to encourage them to screen. And if they had a patient who was straightforward, so just like the simplified algorithm would suggest, very few contraindications that they should treat that patient themselves. You can imagine in our primary care setting, there wasn't a ton of individuals that were identified, but it was very successful. And in Illinois, it served two purposes, both giving them confidence, because I agree, H. pylori therapy is much, much more complicated than hepatitis C treatment. And they don't always do that correctly. But not only did they gain confidence, but in Illinois, we have, we're one of the states that still requires a certain degree of education in order to be a prescriber. So you then either have to be ID, GI, or hepatology, or you have to have gone through a certified learning program of some sort. So it allowed all of our residents to graduate as certified hepatitis C treaters. And we have continued that program. Now it's on autopilot now. We no longer monitor it. We just hope that they reach out if they have questions. So hopefully they're still screening. Probably not a bad time to revisit the program and see if it faded away, and demonstrate that ongoing learning and interventions are necessary in order to continue to engage in a behavior. But we have tried hard to move hepatitis C treatment to an alternative treater.
Good. Thank you very much. And then just to touch base on something, Tatiana, you brought up, and I want to hear from both of you, is that, the treatment guidances for hepatitis B certainly have expanded. And, one of the important things that guidances are now evolving toward is not only just treating hepatitis B as a viral infection, but also this concept of shared decision making. And just in your own practices, when you sit down with individuals now, the WHO guidance was really interesting that you had so many indications where HPV DNA wasn't even part of the recommendation, which I realized was mainly for low and middle income countries, but it was very interesting. But how do you have you evolved here? Because I'm a big believer, particularly Tatiana, with the functional cure rates that are coming, that we need to really make sure that these hepatitis B infected individuals don't develop complications such that when we can start achieving functional cure at high rates, my own opinion is then when we get there, if it's like Hep C treatment, if you get functional cure at DAA rates, we're going to be treating everyone. There's just no question. But the question is, how to, in this period of transition, should we be approaching these individuals? Tatiana,
Yeah, well, I think I really like that what we're anticipating with the ASLD guidance is that there will be commentary on shared decision making, because the reality is that is what we practice on a day to day basis. If the patient is not motivated to initiate or adhere to treatment, then honestly, it's not really benefiting anyone if they start and stop or just choose not to start in general. So I do think there has to be a component of shared decision making and making sure that the patient has readiness to initiate treatment and will adhere to treatment. However, I also think that sharing specific recommended guidance that's based on data is very important to guide that decision making process. So many patients do like to hear that from the data that we have available, if you have a viral load over 2000, then you're at higher risk of liver disease progression. And sharing that data and the guidance with the patient is helpful in informing the conversation.
yeah, and Nancy, how have you evolved now, just in the particularly just in the past few years?
No, I agree with Tatiana. I mean, no, it doesn't matter whether it's Hep B therapy or hypertension treatment. Your patient needs to understand that the therapy is going to have long-term benefit in order to be adherent with it, especially when they don't feel poorly. And some of my patients really say that their drugs make them feel badly. I am just battling a guy who has liver cancer and needs to get immunotherapy and probably local regional treatment if I'm able to engage him, and has not tolerated entecavir or tenofovir in either forms because it gives him gastrointestinal distress. Now, I not having Hep B, think that that's hard to understand, but I have to get this patient engaged in treatment, and without that shared decision making, he's not going to stay on his therapy. I think one of the most important things that we have evolved with is that we are less paternalistic, minus that one patient where I feel I'm still a little paternalistic, and more in the message of education, understanding that risk benefit ratio for the patient as opposed to you have this infection, the guidelines say you should do this, please do this. Because it doesn't adherence just isn't as good if you tell them what to do as opposed to understand where they are and how we're gonna keep them in a place where their health is their priority. I also find that engaging the family, sometimes you don't realize what a parent might be telling their child, especially in some of these, situations where multi-generational families all live in the same place. There might be some, misconception of what treatment is or why you would undergo treatment or alternative, therapies that they might be recommended. And so, that shared decision making allows you to have a more neutral platform to talk about some of these things we probably missed in the past.
Yeah, agree completely, and I think you both said it very well. The guidelines are now reflecting what we've been doing for years. Just to wrap up, one of the most important things, Nancy, you brought up, because DA therapy is so effective, is how to make sure that once we've cured our hepatitis C patients, they still have good liver health. And one of the things that you said, which we all struggle with, is essentially after SVR. So cirrhosis patients who we see now, some of these older people, they're cured. No controversy there. We have to keep watching them. Some of my patients actually wind up with MASLD after SVR. Some unfortunately drink more than they should. But also, it's really challenging in the F3 patients. And I was just curious because, as you said, F3, I have my own, if you will, approach to these F3 patients who we screen, who we don't screen. For instance, some of them I'm convinced advanced fibrosis was because of inflammation. And, if everything normalizes, I think they're okay to be dismissed from care. Yet there are other F3s that, I just say, unfortunately, you can't leave clinic. Nancy, can you just share sort of how you go through your own sort of checklist as you decide how to follow these patients up after achieving SVR?
Yeah, I try to remind myself that current liver cancer screening is an ultrasound and alpha fetoprotein. These are costly but not high risk interventions. And so, missing a person who's got liver cancer because when liver cancer presents with symptoms, it's almost never curative. And even if it is curative, transplant is not cheap. And so, I think that there are a number of factors, like you already outlined, cofactors such as alcohol, diabetes, obesity, age. I think that if I cure someone that I think has cirrhosis at 30 that wasn't an alcoholic, it's probably inflammatory. If I cure someone at 70 who has cirrhosis, well, that's probably a different scenario. And I'm sure we have all seen patients that developed liver cancer years after cure, even though they had a FibroScan now that's normal, that their platelets are like 250. They had cirrhosis, and we've engaged them in liver cancer screening, and we find liver cancers. So remembering that F3 to F4 is a continuum and not a step, I think is also important. So if you're an F3 plus, I'm probably going to keep you. If you're closer to an F2, then I'm probably going to allow you to matriculate out and not have as much concern, knowing that our non-invasive tests for fibrosis do have error embedded in them. So that the closer you are to cirrhosis, the more I am likely to label you as cirrhotic and not, use the F3, F4, but rather my spidey sense.
Got it. And Tatiana, just in addition to your comments here, what are some of the things you do for the patients that you treat successfully? What are words of wisdom you share for good liver health going along? Because, one of the things that, for instance, SVR with steatosis is something I'm less likely to let leave my clinic for a year or two. What are your, if you will, the things that you counsel patient or the aspects you counsel patients for?
Yeah, so first, just to build on Nancy's point as well. So I just saw a patient in clinic who was in his 70s who didn't even recall his hepatitis C history. And on my initial assessment on him, had a normal fiber scan, but he had a liver lesion that we didn't even he didn't even mention a hepatitis C history. He came to me for a liver lesion. And anyway, despite a normal FibroScan and excellent appearing liver test and normal platelets, he did have an HCC. So it's cases like that that really make you think about how can we really make sure that patients have appropriate follow-up, and also what are the other cofactors that have led to this. And so in this particular patient, there was a significant alcohol history as well. So very much after someone achieves SVR, we do want to speak about the different things that can worsen liver health. So, as Nancy mentioned, alcohol use for sure in those patients that already have steatosis or at risk, making sure that they are controlling their diabetes and their metabolic risk factors. And then to the point of when can we let them go from our clinic, I think this is another area where we can engage our primary care partners. So even if we're not necessarily seeing them every 6 months moving forward after their SVR, to send a message with them to say that your primary care physician should continue to monitor your liver health.
Agree completely. Just Nancy, and we'll just wrap up with another question I get asked frequently by primary care providers after Hep C cure. Do you let your patients drink?
I think if I have a patient who has zero fibrosis, I tell them that special occasion alcohol or following the CDC guidelines for lower risk drinking is probably okay. But if I have I also remind them that things change so that the risk of alcohol changes if they develop diabetes, they have other comorbid conditions, and that there is no safe amount of alcohol. So that there's never been, any consensus that drinking is going to improve your health. I just try to keep them into that safer zone. Certainly, anyone who had more advanced disease or has comorbid conditions like diabetes, metabolic liver disease, I tell them that there is no way I can advocate for ongoing alcohol use.
And Tatiana, how do you counsel?
I would echo completely what Nancy says. I think for sure we look at fibrosis stage a bit in our counseling, but the message from a hepatologist and I think from other providers is clear that there's really no safe amount of alcohol, and especially if you already have a history of liver disease, we really want to be very mindful.
Yeah. And in addition to that, I often share, just because it's done so well, is the Canadian guidance on alcohol use, where they actually quantify some of the harms. And I refer them there as well. And just like both of you, I keep alcohol use to, if you will, ceremonial. Sure, birthdays, weddings, sure, but regular use in the setting of these diseases is just not advised. And I just sometimes here in California, that's not a popular recommendation, but that's just the way it goes.
Not in New York either.
Or the Midwest.
Okay. Tatiana and Nancy, thank you so much for an excellent discussion, and your insights are sincerely appreciated. I hope over the past hour that we've given everybody uh, some tools to go out and, again, not only find your patients with viral hepatitis, but make sure that we can reduce transmission. And as you've seen now, we have therapies now for our chronic hepatitis infections that not only suppress the virus, but upcoming therapies for the first time are going to actually lead to improved functional cure rates, we hope, pending these phase 3 trials. And again, for hepatitis C, we have the tools to eliminate an infection without an effective vaccine. That rarely happens, but with hepatitis C, we have it. And we hope everyone goes forward, and together we can try to continue to achieve our goals of reducing the morbidity and mortality associated with chronic viral hepatitis. Thanks so much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Hepatitis B Foundation. This program has been supported by an independent educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, visit peerview.com/UDA 860.